All right, it is noon, so we're going to get started with our next geriatric boot camp series topic on heart failure for this week. But before we get into today's topic, we do have a couple of housekeeping items we like to get through. So if you're not familiar with who the iPro QIN-QIO is, iPro specifically holds the federally funded Medicare QIO contract Rhode Island, and Vermont. And Clarent helps support Maryland Delaware organizations under the iPro QIN-QIO banner. So if anyone asks if you're working with iPro, or if you know iPro is, or if you're working with health-centric advisors or Clarent, you say yes. And at this point, I'd like to pass it over to Mary Ellen to get us started with some COVID-19 updates.
Thanks, Josh. So on the screen here, hospitalizations as of September 9th, we still saw an increase of 7.7% hospitalizations. CDC did post this morning newer stats that show hospitalizations may be plateauing, but I will confirm that for all of you for next week's update. Deaths, however, continue to increase, 12.5 increase. The latest variants, again, EG.5, which is a member of the XBB lineage, is the leading the charge with the COVID cases that we're seeing. The updated vaccine does closely target the XBB lineage of the Omicron variant, which includes EG.5, so that is very good news. Next slide. And just a reminder for folks that CDC recommended the updated 2023-2024 monovalent vaccine. Everyone aged 5 years and older should get one dose of the updated Pfizer or Moderna COVID-19 vaccine. And for immunocompromised folks, there's additional recommendations as far as getting additional doses. I will stick the link in chat for folks to take a peek at. And just a reminder, CDC has a new webpage, respiratory virus updates. They track the current respiratory illness season and they update it weekly, so it's a really good resource, especially as we get into the fall, and I'll stick that link in chat as well for folks. That's it, Josh. Back to you.
Perfect. Thanks so much, Mary Ellen. So at this point, we're going to get into the heart of the matter, specifically talking about heart failure care within skilled nursing facilities. Our speaker today is Dr. Mriganka Singh, who is an associate professor of medicine at the Division of Geriatric and Palliative Medicine with Brown University. So Dr. Singh, over to you. And you are muted.
Thank you.
Thank you.
Hello, everybody, and thank you for taking the time out to attend this talk and presentation. So please advance to the next slide, Josh. All right, so with medical advances in the management of cardiac conditions, patients are living longer with their cardiac comorbidities. They're getting more medical and surgical care in the hospitals and are often discharged to skilled nursing facilities for continued medical and functional recovery. When they reach the rehab setting, the goals kind of become shared goals between the residents and the facilities. And they're centered around restoration of any loss of function that might have occurred during hospitalization. They also center around preventing new loss of function or deterioration from the level that they came in with. And then the third goal is also ensuring that the patients are set up for success at the time of discharge. And as you might know, successful discharge to the community is a quality measure that CMS tracks for skilled nursing facilities. So with these goals in mind in both the residents and the facilities radar, one of the major focus areas is medical conditions and comorbidities. So optimizing the comorbidities that they already have, preventing any acute medical condition from happening. And if it does happen, then managing that acute medical condition is one big chunk, which may help achieve all these three goals. Next slide, please. So just to give you an idea of the numbers, about 30% of acute myocardial infarction patients, about 25% of heart failure patients, 11% of coronary artery bypass surgery patients, and 20% of valve surgery patients are discharged from hospitals to the nursing rehab facilities for ongoing care. And as you see, these are not small numbers, and we need to get really comfortable in getting these patients to the goal, as I outlined in the previous slide. Next slide, please. And briefly, some epidemiological statistics for heart failure. I'll mostly focus on heart failure in this presentation, although other cardiac comorbidities are as important, as you saw in the numbers. A lot of those comorbidities are also seen in patients when they come to the rehabs. So not all heart failure patients are the same, and especially if they are older. So both the incidence and the prevalence of heart failure increases with age. And in the older adults, they're the leading cause of 30-day mortality and hospitalization. The numbers that you see in the parentheses are comparisons for older adults, which is 75 and older, as compared to the younger older adults. And then not only the hospitalization and mortality, but what makes it complicated to manage such patients is that they have a number of chronic conditions alongside the heart failure that they are coming in with. So about 3/5 have more than 5 chronic conditions. More than 50% have some degree of functional impairment. More than 25% have cognitive impairment and frailty. So taken together, you can see that it makes management of heart failure really complicated and complex task. So the first task is when the patient comes in, it's optimization of heart failure as they come in. And the guideline-based strategies which help us do that center around exercise, cardiac rehab, which is approved and paid for by CMS in certain settings, guideline-directed medical therapy, which involves the use of medications like ACE inhibitors or ARBs, beta blockers, diuretics, and such. And then in addition to that, early involvement of palliative care for symptom management or goals of care, and having ongoing and updated discussions as the condition changes is also recommended when the patients are in any setting, regardless of whether they're in an acute hospital, outpatient, or in the rehab setting. Next slide, please. All right, so we can see how to get to those goals that I mentioned earlier in 2 ways. So we can think of patient level strategies and system level strategies. So optimizing the heart failure when the patients come in is part of patient level strategy. And the other aspect of it is acute decompensation, which might happen when the patient is in the rehab settings. So we'll first talk about the patient level strategies. Next slide, please. All right, so the first step is to prevent any acute decompensation. And that is centered around a close watching of different parameters in the patient, namely fluid intake and output, weight, so admission weight and daily weights, usually again in 2 pounds in a day or 3 pounds in a week. is what we are looking for. In addition to continuing the medications that they came in with and giving them as they are supposed to be given, holding them when certain parameters are met, optimizing other cardiac comorbidities, frequently AFib, because if AFib goes into rapid ventricular rate, then there's high chances that acute exacerbation will be precipitated. Also optimizing medications for coronary artery disease, because if God forbid they have a new onset or symptomatic acute coronary syndrome, then that will complicate the other cardiac comorbidities as well, and they will end up back in the hospital. The other thing to look out for and prevent is any acute infections. So we know COVID is still out there and very much a threat in addition, other kinds of pneumonias, UTIs, catheter-associated UTIs. So any infection, when it happens, can put the patient at risk of acute heart failure exacerbation. So we want to keep a close eye and on these aspects, and that will increase our chances of preventing an acute exacerbation. Now, when we cannot prevent it, then the next step is early diagnosis. And early diagnosis is again hinged on subtle detection of subtle symptoms and signs that might be a new feature on your rounds. So symptoms like shortness of breath or cough, or just feeling lethargic or tired, fatigued out, those may be just the subtle symptoms that you want to pay attention to, because in older adults and as they get even older, the signs and symptoms can be very subtle. And unless our suspicion is high, we might miss it, or we might detect it at a stage when it is obvious and the patient needs more escalation of care. Among the signs that you want to keep an eye out is oxygen requirement. Is there any change from baseline, or is there any worsening of their baseline? Pulmonary exam, again, pleural edema, if there's any worsening or new onset, weight changes. And based on the symptomatology and the signs, that might mean that we get some additional testing. So B and P levels in the blood can be done, chest X-ray can be obtained. And at some point, or ideally in conjunction with all this, an MD evaluation, the earlier the better, will be very useful. If there are abilities to have a teleconsult, that will make things easier. So the MD can early on eyeball the patient and then decide on management. So the cornerstone again is the diuretic management, and depending on what else is happening, if there's a change in mental status, if there is a worsening respiratory failure, then, or if you want to rule out any acute coronary event, then they may need a hospital evaluation. But so those are the ways in which we want to prevent, either prevent early on or diagnose early on, or start the management early on in a way that gives the patient the best outcome and also reduces our rehospitalization. So when the patient is stable, we have optimized it, we have taken care of the acute exacerbation. The next step is how do we set them up for transition when they go back out in the community. So the few things that are really important is ensuring that they have a follow-up appointment with both the PCP and a specialist. Ensure that meds are continued. There is education provided around importance of medication use. There's also in heart failure patients, there's higher frequency of cognitive impairment too. So it's important that the caregivers and family is also involved and may need to have some oversight of care and medication use and care coordination. Instructions, especially with the teach back method, are immensely helpful to ensure that what we just told the patient or the family is indeed received well, and patients understand how they can self-manage the condition and the medications and follow up. All right, next slide, please. All right, so we will talk a little bit about the system level strategies. There are quite a few system level strategies that can be used, but I will focus on cardiac rehab as a system level strategy. Cardiac rehab, which is the provision of cardiac focused exercise and education bundle, has been shown to reduce all cause and heart failure specific readmissions. This data is really for patients receiving cardiac rehabilitation in the community. And Medicare actually only pays for this rehabilitation when it is provided in the community. But it can be offered in the post-acute setting as well, and there are benefits to doing so, although it may not be paid for as a separate entity. And we'll discuss, I'll talk a little bit about why that makes sense. Next slide, please. Yeah. So on this slide, what I'm trying to show is that the skilled nursing facilities are in the center and they occupy a really important place. Because when the patients are in there, they can go either way. They can go to the hospitals or they can go to the community and stay in the community safely. So that's a unique opportunity that the skilled facilities have to even further optimize heart failure management. And about 29% of all skilled nursing facility admissions end up in the hospital. This is not specific to heart failure, but if you look specifically in the heart failure population, then that number is as high as 43%. But on the other hand, there's some good news too. So about 60% of the residents who are in skilled nursing facilities, they end up going home. So that's a good number too. So again, because of their important role, they are in the middle, they can use two strategies in isolation or in tandem to improve heart failure care. So the first model is what you see on the slide as the SNF cardiac model, and the other one is referral to outpatient cardiac rehab. So the American Association of Cardiovascular and Pulmonary Rehabilitation, they recommend that there be integration of cardiac specific rehabilitation components into post-acute care to ensure that safe and comprehensive cardiac care is being provided while they are in the SNF. So the two components that form the part of SNF specific cardiac model include exercise and education. Under the exercise bucket, there is risk stratification. So you want to know which kinds of patients fall into a low risk or a medium risk or high risk for cardiac decompensation or not being able to tolerate exercise well. So that is number one under exercise bucket, risk stratification. The other component is monitoring the cardiac response to exercise, which may mean that they get a set of vitals before and after exercise, that they get their pulse ox done before and after exercise. And also the patients can also self-report how they feel. So what's the exertion level feel like to them before and after exercise? That is important not only to see what the limits are of a patient's ability to participate in therapy, but it's also teaching them so that when they are on their own in the community, that they are aware of how they feel while doing certain activities or while taking part in exercise, and that may just be walking. So when they are aware of how they feel, they may be in a better position to stop that activity and hence prevent pushing the body towards some decompensation or some adverse outcome. And then also discuss with their care providers that I was walking or I was engaged in this activity, and this is the level of exertion that I felt. And so they may be better be able to identify red flags and get in touch with their clinical team. So that is why a perception of what the exertion feels like and monitoring that is important, both in the facility and outside. So if they do that while they are in the facility, they already know how to do it on their own. So that's the benefit. Then the third thing which falls under the exercise bucket is endurance training. So the endurance training helps with improving their function and also better control of their cardiac comorbidities. Under the bucket of education, cardiac specific education, so that is again is recommended to ensure that patients and families are able to self-manage heart failure when they return home. So what do we provide education on? It is education on self-management, self-recognition and management of cardiac symptoms, which is knowing what to do if they get short of breath with activity or have, maybe chest pain or heart palpitations. Then education on survival management, that is knowing what to do if they get some symptoms, some concerning symptoms. And then, and the third piece in the education could be education on the importance of attending outpatient rehabilitation, because many such patients may not know that such a thing exists and is paid for by Medicare in the outpatient setting. And if for some reason they were not able to adhere to this SNF specific cardiac care model, once they're better, they can connect with their provider and obtain a referral to go to outpatient cardiac rehab. All right, next slide, please.
Dr. Singh, I just had a quick question.
Yeah.
You had mentioned that the 29% of rehospitalization of SNF patients, among that, you said around 43% were the cardiac issues that were causing them to be rehospitalized. Do we have any data in the community of that 60%? How much of that is related to heart failure being after they've already been discharged, maybe going back to the hospital?
I don't have it at the moment, but I can follow it up.
Yeah, no, I'm just curious if you know, that'd be perfect. Thank you.
Yeah, and that is what the top arrow is pointing at, that once they get to the community, they may either have a successful discharge, that is go home and stay home for 30 days straight without going back to the hospital or going on to hospice or any other facility. So, but yes, they could possibly end up back in the hospital, even though the SNF discharged them successfully to the community.
Yeah, perfect. All
right, please advance. So this is essentially laying out, what goes into if someone were to implement a skilled nursing facility cardiac care model, what are the components that would be in place? And that's the bottom box that outlines the two buckets of exercise and education that I just talked about. In addition, there are some characteristics of these patients which are linked with successful discharge or improved outcomes. And so, although not strictly falling into the bucket of cardiac rehab in a nursing facility, these are still important to be aware of, identify, and optimize. So things like cognitive status, physical function, which is of course the reason they are at the skilled facility, depression, pain, any complications they had in the hospital, most commonly delirium, which can further worsen their cognitive function, and other comorbidities. Next slide, please. So there are some conditions to keep in mind when you're thinking about patient risk. So there are some indications and some contraindications. So obviously we don't want to do that when they are in any acute decompensation, whether that is for heart failure or any of the other cardiac conditions. But for the most part, if they have had a recent MI, Medicare usually starts what they call the phase 1 of cardiac rehab, which is 2 to 3 weeks out after an event. So you see on your left the indications for which cardiac rehab can be provided. And this is a step, the risk stratification step, where you can have a cardiologist do this routinely at your facility. So if you have a cardiology group or even a single cardiologist who comes into your facility, you can explore how they can screen these patients on a routine basis as part of your model, and then give you a green signal on, yes, this patient seems to be low risk and is safe to progress with cardiac rehab or not. And then again, that part of the process can be either in person or you can use telemedicine to facilitate that. But that is something that might be a barrier if you were to implement this model. All right, let's advance to the next slide, please. So other barriers that may come into play if you're thinking about integrating a cardiac care model onto an existing SNF model. And as you see through the discussion, these are the things which routinely happen in a skilled nursing facility anyway, right? We provide education about disease management. We provide care coordination on discharge. We do the physical therapy, occupational therapy, but maybe at least for the response, the vitals response before and after rehabilitation, maybe that is something which doesn't happen consistently. From my experience, I know that when someone is not feeling well after therapy, that's when the vitals get recorded, the pulse ox gets checked. So if it is a reactive process rather than a proactive and consistent process, then we may be missing out opportunities for early intervention and early teaching of the patient that this is how your body responds, and so this is where you should stop. So that I just wanted to make that point. But other barriers could be that, yes, there are a number of comorbidities or severity of the comorbidity that can interfere with the patient's ability to get cardiac rehab in the SNF. Maybe they are ESRD patients on dialysis, and that really cuts down on how much and how frequently they can participate. As I mentioned, hospitalization-related complications. So if they come in with infections, they're on isolation or they're delirious, they have high oxygen requirement, those can get in the way too. We already talked a little bit about risk stratification. That could be a barrier, but then you could also work with it and around it. And if they're coming in with fracture repairs or joint replacements, they have comorbid dementia, then that can also be a barrier. But what would it take? It would take standardizing and agreeing upon what components of cardiac rehab can be easily tacked on to your existing processes, and then standardize them and monitor their the adherence on that. And then that would be the way to start doing it. And the other piece, of course, if you cannot offer, or if you are offering this SNF cardiac specific care model, the other piece is connecting them to cardiac rehab on the outpatient. And again, education will be central to doing that. So if they are primed and they know about the benefits of cardiac rehab, even if they're not able to participate when they're with you, with the priming, with the education, they'll be more likely to go out in the community and get connected with the cardiac rehab center. And lastly, cardiac rehab has been around for a while, and we have evidence on its benefit. But the uptake, it's very low. In United States, it's only about maybe 13 to 30%. Of course, there's huge variation depending on geography. And so SNFs, again, are at a unique position to increase that uptake, at the very least by education and priming them up and setting the referral in process if they can, by connecting them with their PCP. So most of the older folks that come into SNF care are the ones that are maybe least likely to seek out cardiac rehab in the outpatient setting. And so it becomes even more important, if I have them here, can I offer them the chance of participating in cardiac rehab while they are here? Because otherwise they may not be able to continue or go to cardiac rehab in the outpatient anyway. So that is, I think, the last slide. Yeah, I will take questions if there are any.
Thank you so much, Dr. Singh. I have a question, because I think I completely agree with the cardiac rehab principle in the SNF, and it's something that I've actually had clinically to do in the last couple months on a couple of patients, and bringing things up in terms of the standard of how aggressive we are with the rehab. Some barriers that we encountered were that the rehab folks were a little bit uncomfortable being more aggressive with the cardiopulmonary component of their rehab. And it's something that I, as a physical therapist myself, I think we need to be pushing more, and getting them more comfortable with, pushing the limit. I think we cater to people a little too much in our practice. So I thank you for bringing that up. It's great.
Yeah, thank you. And yes, maybe if there is some specialty expertise available, even through teleconsults, that might improve the confidence of the staff and also the patients to participate more.
So Dr. Singh, we have a question. Would you suggest that directors of nursing or others go to cardiology offices to see if anyone wants to partner with cardiac rehab?
Certainly. I mean, getting the word out that, or maybe a better partner could be the hospital, right? So hospitals are the ones that are discharging heart failure patients and hoping that they stay safe out of the hospital. So maybe hospitals would be a better partner, and you could vertically integrate at least this cardiac care model with them. And cardiology offices might also be good partners. I don't know how it is in most places, but I imagine that the hospital might have presence of community cardiologists too. So if there is some integration between outpatient practices and the hospital, then it would make it easier for you to get them on board as well. I hope that answers your question.
Right, and like in our system, we have a heart failure clinic, so collaborating with the heart failure clinic would be great, and working with the outpatient cardiac rehab. So, and what the particular case that I was mentioning earlier, one of them, we had to push to get a cardiology appointment after an MI, and then push for, because once they have to get the cardiology appointment to get the approval for outpatient cardiac rehab. So, just getting that process started was a little slow. And getting the appointment and then getting the referral for cardiac rehab, so that once they leave the facility, they're already set up to move forward with their cardiac rehab. So there are lots of barriers, and I know our practices, our cardiology group has been very successful at reducing some of those barriers, but there's still a 3 to 4 month wait list for outpatient cardiac rehab.
Which again emphasizes the point that if we can have an integrated model in the facility itself, then that gives them some advantage and some benefit before they can do it routinely in the outpatient setting.
Thank you,
Agree.
Dr. Singh, and thank you, Betty, for that question. That was fantastic. She did comment that you did answer her question, so thank you again. Do we have any other questions before we move on? Not seeing anything in chat and nobody coming off mute. So we'll advance to show some references that that Dr. Singh had mentioned throughout today's presentation. And then here's our contact information as well. If you have any questions related to your quality improvement initiatives, feel free to reach out to anyone of us here. We're here to help support you with your quality improvement work. If you also know anyone who missed out on today's session, we have this session being recorded, so we will be able to play it again tomorrow at 3:30. So I encourage anyone that might have missed out, that should be listening to this session, to check out our recording tomorrow at 3:30. And then, so that'll be it for today's session. Everyone is free to go. We're going to be able to close it out. If you do have an opportunity, please put a comment into chat if you thought today's session was beneficial for you. It does provide us with some insight to model future education. So that'll be it again. Thank you so much, everyone, for joining.